So today I have the pleasure of introducing Abby Hayes. Abby is a rising sophomore at Yale University, and one fun fact about her is that she used to be a competitive gymnast. Good luck, Abby.
As Eric said, I'm Abby, and this summer I researched the impact of emergency department pain plans for pediatric and young adult sickle cell patients on emergency department visits, hospital admissions, and length of hospital stay at Benioff Children's Hospital, Oakland, or BCH. Now, before I get into the specifics of my project, I wanted to give a little bit of background on sickle cell. So sickle cell disease, or SCD, is the most common heritable hemolytic anemia. It is also, by and large, most common amongst Black people, as Zara mentioned earlier in her presentation. And SCD stems from a substitution of the amino acid valine for glutamic acid at the 6th position of the beta globin chain. And this is what results in the formation of hemoglobin S, or HbS. And if you look to this portion of this graphic, it is showing you that substitution. And the membrane of HbS then becomes irreversibly injured as a result of multiple cycles of deoxygenation-induced polymerization and reoxygenation-induced depolymerization. And this is what actually causes the sickled cells. And they are showing you that process of polymerization right here. And then it's leading right into the sickling. And then these sickled cells can then obstruct blood flow, which in turn can cause vaso-occlusive crises, or VOC, which are the most common manifestation of SCD. And these sickled cells block blood flow by sticking to the neutrophils and platelets and the endothelium. And it just makes it a lot harder for blood to flow, as you can kind of tell from that portion of the graphic. And since VOC are the most common reason for emergency department visits and hospital admissions, BCH implemented individualized pain plans in an attempt to avoid ineffective pain management at the beginning of admissions, set an expectation for weaning, and to get patients discharged in a reasonable period of time. And I put up an example of a generic ED pain plan right here. And as you can see, it includes the amounts of medication that should be given, the types of medication, as well as the way in which it should be given for that particular patient. This is just a generic one. And now, finally, since SCD patients cite the care received in the emergency department as the area of the healthcare in most need of improvement, which makes these projects like these, whose focus lies in analyzing the effectiveness of emergency department improvement interventions, particularly important, because this is really the area of the care we need to focus on. And now, this study was a retrospective analysis of patient records spanning the year before and after the implementation of their ED pain plan. And we included all patients with individualized pain plans that received all of their emergency care at BCH during the aforementioned time period. And for each patient, the following information was collected: the sickle cell genotype, the biological sex, the age at implementation of pain plan, the number of annual ED visits in the year before and implementation and after the implementation of the pain plan, and the number of admissions and length of each hospital stay in the year before and after implementation. And all of this information was collected from the EPIC system and then put together into an Excel spreadsheet. And now on to the results. So this top table shows that the average length of hospital stay actually increased by the average length of time in ED increased by an average of 6.96 minutes. It went from 434.88 minutes to 441.85 minutes. However, this difference was not significant, as you can see from this p-value of 0.8432. However, the length of stay was found to be significant. And so the length of stay pre-intervention was found to be 6.55, and then it decreased to 4.00. And the p-value we found for this was 0.0119, which means that this finding was significant. However, this finding was likely because of the inpatient pain plan and not because of the ED pain plan. However, since the inpatient pain plan, it's really hard to find the date created. We were not able to do this same year after, the year before and year after. So this result is a little bit hard for us to analyze accurately. And then for the next steps, we would also like to collect data on opioid usage as well as patient satisfaction throughout the stay. And we would also like to complete these analyses with inpatient pain plans and be able to really figure out all of these dates created so that we can do those analyses and compare them to the effect of the ED pain plans and just look at their effect in general. And then finally, we would also like to look at how the effect of these pain plans change over time and really how they work over a longer period of time, because we're only looking at a year after. And fine, I just want to thank SSRP leadership and my amazing mentors and just everyone, because this was great. So thank you.
Fantastic. Nicely done, Abby. All right, who's got a question for Abby? Miriam, you got it first.
Hi, Abby. Great presentation. I was just wondering, what was the most interesting or fascinating thing you found when looking at the patient records?
It was really interesting looking through the patient records because it's really like you're seeing this person's almost life as you look at it, as you see all of these visits. And someone else from their project, and I'm so sorry I can't remember who exactly, was talking about the readmissions. I think it was Monica. I'm really sorry if I'm wrong. But what I saw was literally that, is there'd be patients that come into the ED twice in one day because they just couldn't get better. And there was just such repeated visits, and they'd be long lengths of when they didn't come in, but when they were coming in, it was just these very concentrated number of visits in this short period of time, which was just so sad to see. And so that was the most surprising part, most interesting part of these patient records.
Monica's got your follow-up since your project was similar.
Yeah, I'm just wondering more about why you might think that for your first result, there was no difference, but then there was a difference in the length of stays.
That's a great question. I'm not sure. I would say, I think part of it is that we were only able to look at 9 patients for that period of time versus the entirety of the patients, because those are the ones that received all of their care at BCH, and then we were really able to figure out the exact date of the ED pain plan creation. So I think more people might have been easier. And also, I think just because we weren't separating out maybe if people were getting admitted to the hospital or if people were just going into the ED and getting released, and I think that can affect it. And there was no real difference. It just kind of stayed the same. So I'd wonder, but that's a great question that I had not thought about until literally this moment.
Last question,
So.
Erica.
Hi, Abby. I was just wondering, because I hear a lot about how people with sickle cell disease often feel pain, and it's like really awful. But I was wondering, like, do you know where they feel the pain in their body? Like, is it like a whole body pain, or does it centralize in one area?
So it depends on the person. That was one thing that I was actually noticing in the patient charts, is sometimes they'll have a note that's like, this person was feeling pain in their normal sickle cell spot in their arms or their legs. It's very different based on the person. It's this pain, I believe, in part comes from the blood flow is blocked, and so they can't get enough oxygen. So it's kind of different based on the person. But I think some patients might feel everywhere, some patients feel in particular places.
Thank you.
Great question.
Great question. Nicely done, Abby. All right.